Welcome to Patients at Risk, a discussion of the dangers that patients face when physicians are replaced with non-physician practitioners. I'm your host and the co-author of the book, Patients at Risk, The Rise of the Nurse Practitioner and Physician Assistant in Healthcare, Dr. Rebecca Bernard. As non-physician practitioners increasingly provide more patient care, experts note a commensurate increase in medical malpractice claims. Today, I'm delighted to welcome medicolegal advisor, Bob Pegritz. Bob is the author of Hospital Confidential, an expose of medical malpractice cases. And as a former surgical physician assistant, he is uniquely positioned to discuss the medico-legal implications of non-physician practice. Bob, welcome to the show.
Thank you very much. It's good to be here.
Well, I really enjoyed your book, Hospital Confidential, and I'm really excited to talk with you about that and also about your experience in the medical legal field and your thoughts on non-physician practitioner malpractice. But why don't we start out by having you tell our audience a little bit about yourself?
Thank you very much. I was born in Smock, Pennsylvania. It's about a bustling 300-person community about 50 miles south of Pittsburgh. The entire town was populated with either coal miners or steel workers. After I finished school, I joined the Air Force and I became an air medical evacuation medic. I then was, for my efforts, I was sent on a 13-month vacation to Vietnam, and I worked in helicopters. I was the guy in the bottom of the helicopter that took care of the patients and got them back to safety. I got out of the military. I started working as a surgical assistant in the University of Pittsburgh, which at the time was called Presbyterian Hospital. Now it's called UPMC. After that, I went to a smaller 150-bed hospital in Southwest Pennsylvania, and I assisted. My surgeons were a thoracic surgeon, a general surgeon, orthopedist, a urologist, and an OBGYN.
In my research about the physician assistant profession, it sounds like you were actually the exact type of person that the profession was created for. I think the whole idea was to take medics that were coming back from Vietnam and other places that had some basic training in medical and had a lot of experience in the field, and then help them to kind of find this niche. Am I right about that?
You're exactly right. And as a matter of fact, I was grandfathered into the program. I had taken the certification course and was grandfathered in. And I'm proud to say that 11% of all the physician's assistants that are out there now are military veterans.
So you worked as a PA for a number of years, and then you had a little transition in your career, and you started getting really interested in the medico-legal aspects of medicine. How did that come about?
After a midlife crisis and a trip to audio engineering school, and then another trip as an intern to Nashville at the Grand Ole Opry, I came back to Wilmington, Delaware, and was teaching a Morse code class when I said to a friend of mine at the break, if I don't hear from Nashville pretty soon, because they promised to hire me as soon as the slot was open. And I said, if I didn't hear from Nashville soon, I would have to go back into surgery. That caught the ear of a plaintiff malpractice attorney who was one of my pupils. And he approached me and said, do you understand what all that means in medical records? And I said, of course I do. And he said, I would really like to employ somebody like that every now and then. And my only question to him was, do you have friends who feel the same way? Next thing you know, I was a medical legal consultant and have been that way for 32 years.
It sounds kind of like right place, right time, and things were just lined up to work out well for you.
Some people would say I lead a charmed life.
Well, it sounds like you've worked very hard as well. And that leads me into a discussion about your book, which is called Hospital Confidential. And it's fascinating. I downloaded it to my Kindle and I could not stop reading it. This is a book full of just fascinating malpractice cases, or also some medical mysteries. How did you get interested in writing, and how did you pick these cases?
Well, the interesting thing over the years, Rebecca, is that these cases came to me, and the book has 13 of these stories. Every one of them has not been embellished in any way, although they might read as somewhat preposterous. But they actually, I can tell you, everything happened the way that it's written. But I would sometimes at parties or social gatherings, I'd say, well, I remember this case, and I would tell them a story about a case. And I always got the answer, Bob, you should write a book. And that's exactly what I decided to do.
It sounds like you were the life of the party, and you're also an excellent writer. I just want to tell you. And one of the really interesting things about this book is that you tell the story and you give the vignette. And then at the end of each case, you have commentary by Dr. Cyril Wecht. Tell us who that is.
He's a forensic pathologist, was instrumental in reviewing the Warren Commission on the Kennedy assassination, had done very high-level autopsies on famous people, but he has been known internationally and now works as a medical legal consultant in Pittsburgh in forensic pathology.
How did you come to associate with him and get to collaborate on this book?
Well, Rebecca, the man is a household name in Pittsburgh. And I just decided one day I had some free time, so I called him up and said, "Hey, you want to go to lunch?" And he said, "Yes." And we met, and we have been very good friends ever since.
You know, Bob, I love that story because I have been thinking and listening to a lot of different people talk about how important it is just to take a chance. And if you want to do something, you want to meet somebody, just ask. And you just gave a perfect example of that. Let's talk a little bit about some of these really fascinating cases in your book. One of the stories that you tell that leads in is of a surgeon who botches a uterine bleeding repair after a woman has a cesarean section, leaving the young woman infertile. There were so many things that went wrong in this case. And one of the things that struck me was that a lot of the nurses and other staff at the hospital, they noticed that something was wrong, that the doctor didn't seem right, or that he had some problems, but they were all afraid or intimidated or unwilling to speak up. What can we learn from that?
Well, you hit the right word, Rebecca, intimidated. You cannot be timid in speaking to these people, even if you know you're going to get chewed out or if you're going to get ostracized in some way, simply because if a patient's health is at risk or if there is a particular sign or symptom that needs to be reported to the doctor, just because he's sleeping off a hangover in the break room doesn't mean that he's not to be disturbed. You have to sort of develop that fortitude to impart that information on these physicians, regardless of their personality. I will tell you, I have known doctors who have taken patients and said, "Your health is my primary concern," and they're horrible. And I've seen others who, there was one particular orthopedic surgeon that I used to work with. He was one of the crankiest, one of the nastiest surgeons, but he was the best orthopedic surgeon I ever met. He had golden hands.
That is such an important distinction because a lot of times, I know when I'm talking about the importance of physician-led care, a lot of times what I hear is, well, patients prefer nurse practitioners or sometimes even physician assistants because they listen and because they're nice. And what you're pointing out here is, while it's really good and helpful to be nice and to listen, there also has to be a certain level of skill and knowledge that's first and foremost.
There really does. And so you shouldn't feel embarrassed when you're in an office of a medical provider, whether it be a mid-level provider or physician, to sometimes ask about their credentials or ask about their cases, because it's just like purchasing, other things in life where, you want to know a smart consumer is a good consumer.
I think you're so right. You think about how Americans research every little thing, the toaster you're going to buy. And yet a lot of times we don't do that much research when it comes to our healthcare, or we may feel that we don't have a choice, but we do if we can just become more educated and also more insistent that we find out who's taking care of us, what are their credentials. Like you said, we should never be afraid to ask for a second opinion. And also, I always say as a primary care physician, patients should reach out to their primary care doctor, especially if they're looking for referrals to specialists or, just to find out if they're going in the right direction. But what you're saying about being a little more insistent and being a more educated consumer really was something that I saw in your book, which is a lot of times when physicians and nurses and other clinicians got into trouble was when they ignored or didn't thoroughly work up a patient's complaints. And you had several stories in which patients, there was a patient that had severe constipation and it kept getting worse and worse. And nobody really did much of an intervention until finally he had a perforation of his bowel. And these cases over and over again, what you describe are patients and even patient family members saying, please help me. Why do you think it's become so much more common, and maybe it always was in healthcare, for clinicians not to really listen to patients or not to intervene when they seem to have such severe symptoms?
Well, Rebecca, you and almost every other physician in the world knows the quote from Sir William Osler: listen to the patient, and they'll tell you how to treat them. And unfortunately, especially nowadays, sometimes people do listen, which is a wonderful thing, but sometimes people make up their mind a little sooner. As clinicians, diagnosticians will make up their minds, and they'll go down a diagnostic path that may be contrary to what the patient's saying.
That's a really good point. And in fact, they'll try to force the diagnosis down the pathway that they're thinking of, rather than, they call that like foreshortening of the diagnosis, where you've made your decision, and no matter what somebody says to you, you're just locked in on that. And that's just so dangerous. I guess the other thing I wonder about is healthcare has gotten so crazy with the documentation and the demands that, I'm sure everyone's just feeling very burned out and fatigued, and it makes it harder for them to listen to patients, especially I'm thinking about hospital settings. But ultimately, you as the clinician, whether you're a physician, nurse practitioner, physician assistant, nurse, you're responsible for the care of those patients. And one of the things that I thought was interesting in the book were the technical challenges. And speaking of a time now where everything is electronic and we're depending more and more on machinery and instruments, you had a really interesting case of a patient who had a cardiac arrest out in the field. And when the EMS team arrived, their AED, their shocking machine, had no batteries in it.
The patient was in his 40s, and other than this heart condition that came on him quite suddenly, he was in relatively good health. The EMT showed up first, and they had a battery in their automated electronic defibrillator, but they didn't have enough power to produce a shock, but they had enough to make a tracing. And the tracing came back ventricular fibrillation, which we all know is a shockable rhythm. Because the battery didn't work, they got the second battery, the spare, and it was dead. Then they called the paramedics, and the paramedics came with their AED, and both of the batteries in theirs were dead. And then they called a piece of apparatus, a ladder truck that had an AED on board, and it had no batteries at all. And the interesting thing is there was a sign at the fire station, which I actually photographed. And the sign was how to charge, change, and maintain the batteries in the automated electronic defibrillators.
I think about how there's such a dependence on team-based care in medicine. And I always think, you're only as strong as your weakest link. So you have everything, and the patient dies because of a lack of a charged battery. And I think that's just an example of something that can happen in healthcare just all the time. You have to be constantly diligent about your instruments, about your equipment, about your staff, and it really, lives are at stake. And you had another example kind of in the similar vein, in which a patient had thyroid surgery and was being monitored, and they had a pulse oximeter measuring their oxygen on their finger, and yet the patient began to decline. No one realized that the patient was declining. It turned out that the pulse ox wasn't even plugged in, and the patient was desaturating and rapidly becoming unstable.
Even if the pulse ox was plugged in, sometimes the monitors aren't turned on. The alarm might ring at 180 beats per minute. Well, that's excessive. Or if they make it so that the pulse ox doesn't go off, the monitor doesn't go off until the pulse ox is down to 20%.
By then it's
that's
too late.
Inexcusable.
Yeah, by then it's too late.
It's way too late. Yep.
Yeah, I think about alarm fatigue, and I think about all the beeping and all the chaos. I even think about it with electronic health record. I guess you just sort of get used to ignoring these things or just shutting them off. And now when something really serious is happening, you totally miss it. And that's obviously a matter of life and death, like it was in this patient. So I think your stories really remind us that when you are the clinician, ultimately you're responsible for everything, making sure that everything is working. And that's a lot of responsibility. It's something we should keep in mind as physicians, especially if we're supervising non-physician practitioners. Now, you have noticed a little bit of an increase in malpractice cases involving non-physicians, right?
Yes, I have.
Tell us a little bit more about some of the cases that you're seeing.
I have a case that has not gone to trial yet, but it's a case of a nurse who worked in pediatrics, a nurse practitioner, who then decided to go to work as a nurse practitioner in a neurologist's office. She had no training with neurology. So instead of examining the patient or doing a neurological exam as a nurse practitioner, she cut and pasted the medical record for 7 months. And the patient came into the office about once a month. So there were 7 cut and pastes that were done in the medical record. And we learned nothing. But during this entire time, this man was going blind and he ultimately lost his sight.
Oh, so sad. And I'm imagining the patient just trusted this nurse practitioner, assumed that they knew what they were doing or they were consulting with the physician. And I mean, obviously they were a very compliant patient because they're going back month after month. And that's such a sad story. We talked to another attorney who told something similar, where it was a nurse practitioner who suddenly became a intensivist or a hospitalist or a neurosurgical or a NP. And the question is, how do you get those credentials? Because it seems like it's almost as easy as just flipping a switch or just calling yourself such a designation.
Well, if a physician who is an internist or family practitioner or any specialty or subspecialty decides to go into another specialty, they are required to take some sort of training, like another residency. And so why wouldn't that be the same for mid-levels? If they decide that they want to work in cardiology one day and rheumatology the next day, that's a pretty learning curve.
Yes, that's a very steep learning curve. And like you said, it is quite a double standard because I'm a family doctor. And while certainly I can include neurological disorders in my care of patients, I could not hang a shingle and call myself a neurologist. That would be completely unacceptable. I'd be sanctioned by the board. So it is kind of an interesting double standard. So many instances of bad outcomes, and in this case, medical malpractice, is a failure to act, and a failure to act on abnormal findings or to practice outside of protocols. So, for example, you gave a case of a physician assistant that evaluated a child with abdominal pain. The child presented with a rapid heart rate, with tachycardia, with fever, with abdominal pain, and the physician assistant said, it seems like it's acute gastroenteritis and a cold, sent the child home with a sulfa antibiotic of all things. And of course, lo and behold, the child actually had appendicitis. And it reminds me of a case of Betty Wattenbarger, who was a young girl who died when a nurse practitioner did not diagnose her with sepsis. And in the sense that both of these patients had clearly abnormal vital signs, and yet they were not triaged to the next level of care. And, the same thing happened with another case that you explained about, where a patient had mitral valve repair surgery done in sort of an innovative way and started showing signs of decompensating. And just over and over again, nurses were charting this decrease in blood pressure, increase in pulse, and yet no action was taken. What are your thoughts when you see things like that?
If it's cold in your house and the door's open, you close the door. You don't sit there and write about the door being open, or you don't sit there and write about how cold it is in the house or how you're shivering. You get up and close the door. You're very, very right, Rebecca. There's a lack of inaction sometimes. And some of that is that the healthcare provider, whether it be a registered nurse or a physician's assistant or any other provider at all throughout the whole chain, is sometimes reluctant to take action. They feel that what they've done was chart, and that's they've exhausted all of their responsibility in making the observation, reporting the observation on the chart, and when the doctor comes by, he'll see it. Training has to be in such a manner that if you see something that is so far out of whack, something that's so far away from normal, that there has to be some reporting done or something has to be in place. And hospitals many times have these in place when you read their bylaws and when you read their nursing practices and whatnot. you see that they're put into place. Sometimes people just don't do it. And that's when they cross my desk.
Yeah, I think you're exactly right. And that's why they're, in my opinion, having protocols, having policies, having procedures. It's not just for these clinicians here and there. It's for all of us. I have my own office policies and procedures, and they're guidelines so that you remember what you need to do so that you take action. Just identifying a problem isn't enough. You actually need to take the next step to try to remedy it. And I think that's where sometimes we're just seeing a disconnect. And the other thing that I see, and you describe this in your book, were cases in which surgeons or others perform procedures, but then didn't really know what to do when they had a negative outcome or an unexpected effect from it. And that made me think a lot about some of the increase in cosmetic procedures that I'm seeing around. And I'm only imagining that there's going to be more litigation in this field. One of my girlfriends was just telling me how one of her patients saw one of these Medi-Spa nurse practitioners, and they put these thread lifts in their face, which are these barbed threads that get put under the skin. And I guess it's used to give you a facelift. Well, unfortunately,
Yes.
These threads, I guess they have a high chance of getting infected. It's a known complication. And indeed, in this case, the threads got infected. They were already in, they're barbed, so they can't come out. And the nurse practitioner didn't know what to do about that complication. And basically, from what I understand, just stopped responding to the patient because they didn't know what to do. And the patient ended up on IV antibiotics and some deformities and things like that. So it just takes me back to you can get licensed to do things, and you can do things that you really probably shouldn't, but you need to know every possible complication and bad outcome and be available if something goes wrong. And it sounds like that's a common problem that you see across your desk.
Well, it's interesting you should mention this barbed suture. Barbed sutures have been around now for about 6 or 7 years. But what you've mentioned is a clear misuse of a barbed suture. A barbed suture is meant to be used laparoscopically, so that because a surgeon can't stick his fingers down into the laparoscope and tie a knot. But if you have a suture that's got a barb on it, you can pull it till the barb comes out of the tissue, and there it kind of stays. It's sort of a self-tying or a self-sustaining knot. And that is the purpose of a barbed suture. People in dermatology or plastic surgery now are using a barbed suture in this manner, but I do believe that is a misuse of the product. It was never intended to be used in that manner.
Yeah, in my research, it has a very high complication rate. From what I understand, not too many facial plastic surgeons are doing this procedure, but it's one of those things that I guess seems easy or simple to people who really don't have that understanding and training. And it's being offered left and right. And unfortunately, we're seeing some complications, which it really worries me a lot when I see people that really have just a minimal amount of training and expertise doing things, especially invasive things, to patients that they really don't know how to handle or even what the consequences could be.
Well, in this particular case, like you mentioned, this suture, to my best of my recollection and my reading, because I read journals every month, I subscribe to things like Medscape just to keep up on things, and these sutures are non-absorbable, and so it's an automatic foreign body reaction. Not automatic, but it's possible. Whereas if the suture were absorbable and it would be a thin monofilament suture, perhaps there would be a less chance of infection or complication. But it's the choice of the product, and they're getting results of this, but there's been no testing. There doesn't appear to be any FDA approval of use in the face. It sounds to me like these complications happen as a result of a foreign body reaction or something like that.
That's what I understand. And, I'm so glad that you brought up the word science, because doesn't it seem like more and more there's this extrapolation of, well, this should work, so let's just try it. Or a lot of times when I see the literature saying that non-physicians can practice just as well and safely as physicians, and then when you really dig into the science, it's really not very well done. And Bob, actually, the way you and I got to know each other was that you mentioned Medscape, and you saw the article that I wrote about the physician assistant name change and my concerns about their move towards independent practice. And
Yes, I did.
tell me, what are your thoughts on that?
I don't know if the name change is going to make much of a difference, between assistant and associate. And I haven't called myself a physician's assistant ever since I left medicine. And I don't use any letters after my name because I sometimes I see nurses with 18 or 20 letters after. I am not kidding. I have seen 18, and they need to have a 2x4 for a name tag in order to have all the letters get in there. I've always said that degrees are for thermometers. It's what you do, it's what you've learned, and there is nothing like being taught by people that are a whole lot smarter than you, which is why internships and residencies are out there. Nowadays, the trend for independent practice, I mean, there are some states where PAs and nurse practitioners can hang out a shingle and see patients independently. But we saw how that happened in our case that you mentioned previously, that little girl that had appendicitis. The PA said you should go home and eat apples. That's not going to cure an infected appendix. All the apples in the orchard isn't going to cure that. And this is why, the doctor has to have some kind of supervision, oversight. But when that oversight is missing, and when that person might feel empowered to make decisions that maybe they're not capable or qualified for, that's when you get into trouble.
Yeah. And, the response to my article, of course, it garnered a response from the American Academy of Nurse Practitioners and physician assistants. They actually teamed up, which was shocking to me because those two groups don't always see eye to eye on everything, but they chose to get together to respond to my article. But on the comments, and there were over 1,400 on my article alone, it was really enlightening because I got a lot of criticisms, but I also received a lot of support from physician assistants, many of whom don't agree with their leadership. They talk about really wanting to work with physicians and, seeing the value. And so that was really gratifying to see. And hopefully they'll speak out to their leadership.
I would hope so. What's the old expression? The enemy of my enemy is my friend. And
yeah, I think that makes it clear who the enemy is. So
they teamed up, they teamed
sure
up.
Did.
And I'm so sorry that had to happen. I really, for all those mid-level providers, I apologize on behalf of all of them, saying,
oh, well, I got a lot of nice supportive messages, and I have gotten to the point in my life and in my career where I realize how important it is to speak the truth from my heart and what I believe, because I always say, I'm not only a doctor, but I'm a patient. I'm a patient now, and I'm going to be a patient in the future. And really, it's all about making sure that patients have the best quality of care that they can. I want to encourage all my listeners, you've got to check out this book. It's called Hospital Confidential. Really well written, a quick read, super entertaining, lots of lessons to learn. It's available on Amazon.com, and the author is Bob Pegritz, and we'll have links to that book. So thank you so much for joining us. We look forward to seeing you on the next podcast. Of course, I encourage you to get my book that I co-authored with Dr. Naran Alajba. It's called Patients at Risk, The Rise of the Nurse Practitioner and Physician Assistant in Healthcare, also available at Amazon and at barnesandnoble.com. And if you're a physician and you'd like to learn more about helping promote physician-led care, I would love for you to join the group Physicians for Patient Protection, our website, physiciansforpatientprotection.org. Thanks so much. We'll see you on the next podcast.